Good morning, and thank you for joining us for today's webinar, Prostate Cancer CME Series and Treatment Across the Prostate Continuum for Primary Care Clinicians. I'm Ruth Adewuya, and I am the Managing Director for the Center for CME, and I am pleased to be able to start up this webinar today. This webinar is targeted towards primary care clinicians, and it will include a discussion on the historical landscape of testing, blood-based diagnostic markers and screening, the latest in diagnostics, the role of genetics and genomics, and it will highlight existing disparities in prostate cancer. I also want to point you to other opportunities in this series. Dr. James Brooks discussed prostate cancer screening on Stanford Medcast, and a case-based self-paced module for primary care clinicians will be coming out in the fall. Today, we will be utilizing the Q&A feature in Zoom, and questions will be answered after each topic. If you do have any technical issues, please use the chat function, and our Stanford CME staff will assist you. And so with that, I will pass it on to our course directors for this webinar to introduce themselves, Dr. Kaki and Dr. Shah. So I'll pass it on to Dr. Ali Kaki.
Good morning. I'm Ali Kaki. I'm a clinical assistant professor here at Stanford University and a genitourinary medical oncologist here at Stanford Cancer Center. I'm excited to be co-directing this course with my colleague, Sumit Shah, and I'll pass it over to him to introduce our first speaker.
Thank you, Dr. Kaki. My name is Sumit Shah, clinical assistant professor of medicine and oncology at Stanford University with a research focus on novel immunotherapy clinical trials in urologic cancers, as well as healthcare delivery systems utilizing digital health. It's my honor to introduce our first speaker today, Dr. John Leppert. Dr. John Leppert is a professor of urology at Stanford University, as well as chief of urology at the VA Palo Alto healthcare system. In his clinical role at the Palo Alto VA, Dr. Leppert coordinates the multidisciplinary urologic oncology clinic, which cares for veterans with advanced urologic cancers from across the West Coast and the Pacific. Dr. Leppert's research includes work to better estimate life expectancy as a way to identify patients appropriate for prostate cancer screening and to personalize prostate cancer treatment decisions. Dr. Leppert will be discussing the historical landscape of prostate cancer testing, blood-based diagnostic biomarkers, and testing.
Good morning. All right, I hope that worked to share my slides. I am excited to be part of this CME webinar this morning and to share a bit of the history about prostate cancer and prostate cancer screening. This has been a mountain of literature to go through, and so today I'm going to focus on the highlights with this historical lens and specifically look at how PSA-based screening has changed the care for patients with prostate cancer. Let's see. So with every talk, I share a reason why I care about the topic. And this is a picture of my grandma and my grandfather at my wedding. And my grandfather is a longtime prostate cancer survivor. But more than why I care about prostate cancer, I mean, we've all been touched by cancer in many different ways. We should all care about prostate cancer, even though we commonly think about prostate cancer as an indolent disease that may not be potentially as scary of a diagnosis as other types of cancer. In the United States, prostate cancer still makes up the most common diagnosis for men and the second most common cause of cancer-related death for men. And when we think about whether or not a cancer is a good cancer to screen for, there are several criteria that make it relevant. So we know, based on the high prevalence, that prostate cancer would be a good cancer to screen for. We know that it's serious as the second most common cause of cancer-related death. But the other half is, if we find a test, can we design some kind of screening test that will find prostate cancer? And then once we find prostate cancer, can we effectively treat it? And that's what I'm going to be focusing on a bit today, as how PSA-based screening has played into the detection and then treatment of prostate cancer. we've lived through this experiment with the introduction of PSA, this natural experiment. And if you look at the brown lines in both of these charts, you see that the detection of prostate cancer spiked dramatically in the early 90s with the introduction of PSA. It's also come back down more recently, and we'll look into why that is. And if you look at the deaths per 100,000 men in the United States, you'll see that there was a small spike in the death rate for prostate cancer in the early 90s. But since that time, we've cut the death from prostate cancer significantly, and we have a trend that continues to go down with some different variations in the most recent years that we'll talk about. So we need to look back at the history of PSA-based screening. And I love this picture. It's taken by the Cassini spacecraft as it was passing Saturn. It took a photo of Saturn and looked back and caught Earth in the background. And I just think that this is a great example of perspective here and how perspective can be used to look at the history of prostate cancer. So first, when did we even decide that prostate cancer was a thing? So if we look at a timeline, it was only in 1852 that prostate cancer was considered to be distinct from BPH. Without a screening test, without a diagnostic test, without x-rays, the only way to know that someone had a prostate problem was from their symptoms. And so patients presented with urinary retention, they presented with failure to thrive, and they died from wasting disease related to their metastatic cancer. But it was only in 1852 that we really understood that prostate cancer was different than BPH and that there were multiple conditions that could affect the prostate gland. Shortly thereafter, in the 1890s, we have the first x-rays, and in 1882, Halsted first described the radical mastectomy. And this is an interesting consideration in the history of cancer in general, but also for prostate cancer, the idea that a cancer would start in an organ, and that if you removed the organ early enough, you would prevent its spread to distant metastatic sites. So this is really the foundation for why screening may be effective for some cancers. And in 1905, the first description of a prostatectomy for cure for cancer was described. So this was Hugh Hampton Young in 1905. And this was a surgery that went transperineally simply because other attempts to operate on the prostate were very bloody and unsuccessful. And in his description of this first surgery and looking at the pathology from the patients that he treated, he described things that are actually very relevant today. Prostate cancer is more common than supposed. It remains for a long time within the gland, so within the prostate, and then it can spread to the lymph nodes of the pelvis and metastasize to other systems, including the bone. And his idea was that cure could only be expected by radical measures, because if you don't remove the prostate cancer, it would eventually spread. This we'll debate later. But the prostate cancer story includes some other things that are also very fascinating. So in 1940, Huggins and Hodges described that prostate cancer was an endocrine tumor, that if you remove testosterone as a fuel, you can place cancer into remission. And so for the first time, you had a treatment for patients with metastatic prostate cancer that was effective, which was an orchiectomy. Huggins also described the endocrine nature of breast cancer, and in 1966, he won the Nobel Prize for this discovery, one of the two urologists that have won Nobel Prizes. And in his short series, he had 21 patients with metastatic prostate cancer. They all got better with orchiectomy, and they got better from stages of late cancer, weight loss, wasting, and basically these are patients that didn't have any treatments before this time. And we end kind of the early period of prostate cancer history in 1974, when the Gleason grading system was introduced, and we've had for the first time a way to look at prostate cancer under the microscope and come up with a prognostic and predictive biomarker. And then in 1980, when Walsh described the radical prostatectomy as a retropubic approach instead of a perineal approach, and this, oh, we missed one other thing actually, which is another link from Stanford, which is Dr. Bagshaw introducing the idea that not only surgery could be curative for prostate cancer, but radiation could be as well. So they described radiation to the prostate as well as the pelvic lymph nodes, and in some cases the retroperitoneal lymph nodes, with reasonable success. And so now we have treatment options for localized prostate cancer for both surgery and radiation. And with surgery, the big issues that they addressed was bleeding by understanding the anatomy of the blood vessels around the prostate, and sexual function after surgery by understanding how the nerves ran to the penis along the lateral borders of the prostate. And if you could preserve these nerves, you could preserve sexual function after surgery. And so with those discoveries, we kind of exited the early period of prostate cancer where we now had some treatment for patients with very advanced disease, which was an orchiectomy. We had treatment for patients with localized disease, which was either surgery or radiation. And we had a better understanding of prostate cancer based on the Gleason grading score. And in that context, PSA was then introduced. So in 1987, Stamey described PSA in the New England Journal of Medicine. And basically they looked at 120 men that had prostate cancer, many of them with advanced disease. Remember, we didn't have a way to detect cancer early at that point. And they found that the PSA was proportional to the tumor burden, and that if you removed the prostate, that they would have an undetectable PSA after surgery. But they also had an interesting finding, which was that PSA was also elevated in BPH, which has been one of the challenges with prostate cancer screening in general. In 1991, Catalona et al. Had a paper that described the PSA could be used as a potential screening test. They looked at 1,600 men. They looked at a PSA, and if the PSA was over 4, a cutoff that will be familiar to everyone, but this is the first description in a major prostate cancer screening trial. But if the PSA was over 4, they underwent a DRE and an ultrasound to look for prostate cancer. And if your PSA was over 4, 22% of men had cancer detected. And if the PSA was over 10, almost 2/3 of the men were eventually diagnosed with prostate cancer. So they determined that PSA-based screening was better than just a digital rectal exam alone, which is not surprising. And so now we enter the modern period where PSA screening was available. And if you have a common cancer, that's a common cancer killer, and now you have a screening test that's a blood test, minimally invasive and easy to administer, you can imagine the enthusiasm for adopting PSA screening. And this has been the natural experiment that we've lived through. But there's been several important trials now in the modern period that have determined the efficacy of screening and treatment for prostate cancer. So the first one was published in the New England Journal in 2002. So the Spcg trial looked at treatment for men with localized prostate cancer. It was in 14 Scandinavian centers, about 700 men, and men were randomized to surgery versus watchful waiting. I imagine this is a very difficult trial design to consider, where you're going to randomize patients that are willing to either have something invasive like a surgery or to monitor their cancer. And at 6 years of follow-up, they had a reduction of the risk of cancer progression. So they had a significant reduction in prostate cancer metastasis in the men that were treated with surgery. But in the early follow-up, they had no difference in overall survival between the groups that elected to have surgery versus watchful waiting. The second to the group of data that were released came in 2009 with the Erspc trial and the Plco trial. These were both published in the New England Journal. The Plco trial was based in the United States, a large trial of more than 75,000 men. And they were randomized to PSA screening, which was supposed to be annual over 6 years, versus a control where patients were not directed to have PSA-based testing or not. When they found that the cancers were detected more commonly in the group that had PSA screening, they also found that half of the cancers that were detected were considered low grade. And in their initial presentation, they found that there was no difference in prostate cancer mortality after 15 years of follow-up. And if you look at the figure on the right, you can see that the screening group did have more cancers detected, but the control group actually had a fair number of cancers detected as well. And we're going to come back to that finding. The second trial from 2009 was the Erspc trial. So this was a trial in Europe, 180,000 men across many European countries and centers. And at 9 years of follow-up, there was an increased detection of prostate cancer with PSA screening. And there was actually a benefit with a risk reduction in prostate cancer specific mortality at 9 years. So a little more follow-up than the Plco trial. And we'll also talk about how the populations in the Erspc trial were different than the Plco trial, which may explain this difference in outcomes at these early time points. And so then in 2012, we have two pivotal events in the history of prostate cancer screening. So the PIVOT trial was published, and then the USPSTF recommendation in 2012, which changed the landscape for prostate cancer significantly. So first, the PIVOT trial. So the PIVOT trial was run in 8 VA centers as well as the NCI. 730 men were with localized prostate cancer were again randomized to surgery versus observation. And at 10 years of follow-up, there was no difference in prostate cancer mortality between those two groups. There were some subgroup analyses that suggested that there was an overall mortality benefit if your PSA was high at the time of entering the trial. We're going to come back to this trial again to talk about the PIVOT trial and its strengths and weaknesses. But the combination of the PIVOT trial and the Plco trial led to the 2012 recommendation by the USPSTF to stop PSA-based prostate cancer screening. So this was for all men, regardless of age or risk. This was obviously controversial. There's been quite a debate going back and forth, but we now have our natural experiment to look back on to decide whether or not this was a good decision or not. Since 2012, there's two more things on our timeline that I'd like to focus on. In 2016, the PROTECT trial released, and in 2018, the USPSTF revisited their recommendation. So let's start with the PROTECT trial. So in this trial, more than 80,000 men received a PSA test. Of the men that got diagnosed with prostate cancer based on this PSA screening, 1,600 agreed to be randomized between active monitoring versus surgery versus radiation. And the prostate cancer specific mortality in this group with localized prostate cancer was very low. It was about 1% of men at 10 years had died from prostate cancer, regardless of their treatment group. But surgery and radiotherapy both showed a lower incidence of disease progression, with fewer patients progressing to metastatic disease. And now we need to go revisit the trials that had more time to mature that we had on our timeline. So the Spcg trial back from 2002. So this was the Scandinavian trial, and they've had multiple publications of a continued follow-up. They're now at 29 years of follow-up. And with enough follow-up, there is a significant reduction in prostate cancer-related death, but there's also a reduction in overall death, so that prostate cancer screening with PSA actually improved overall survival for the men in the screening cohort as opposed to the control. And you needed to screen many men, and you needed to treat about 8 men to prevent 1 death from any cause. So this was not just prostate cancer specific mortality, but all mortality. And they estimated that about 2.9 years of life were gained for men that had prostate cancer treatment as part of this prostate cancer screening. So this is updated data from that 2002 trial, the first one to be published, which is why we have the longest follow-up from this trial. And now let's go revisit the Plco trial, which was this trial in the United States, which was negative for showing any improvement in prostate cancer mortality or overall mortality. But if you look at a survey that was administered after the Plco trial, you find that 90% of the control group had PSA screening versus 99% of the group that was in the PSA screening arm. So essentially the Plco trial is not an effective trial to examine whether or not PSA screening or prostate cancer treatment is effective. Instead, you have this very high intensity screening versus slightly higher or slightly lower PSA-based screening in the control group. And so it's not surprising that we don't see a difference in either prostate cancer outcomes or overall mortality. The 2009 Erspc trial, this was again in Europe, has published their updates as well. So at 13 years, there's a reduction in prostate cancer mortality for the group that had prostate cancer screening. And you have to invite about 780 men to screen for prostate cancer to prevent 1 prostate cancer death in this cohort. The PIVOT trial, which was run out of the VA and the NCI here in the United States, that showed that for localized prostate cancer, there wasn't a benefit in overall survival for treatment of those veterans. Almost exactly half of those veterans had died within 10 years of enrolling in the trial. And we often talk about life expectancy as a reason to screen for prostate cancer, which is an indolent disease. You have to have sufficient life expectancy for this treatment or screening program to have a benefit for the patient. But the patients that enrolled in Pivot were actually sicker than the veterans that were cared for with prostate cancer across the rest of the VA during that same time period. And this likely comes from the fact that you were randomized to either surgery or watchful waiting. And I'm sure that the patients and the doctors would often consider that it would be a harder decision if patients were relatively less healthy about whether or not surgery would be the right thing for them. And with follow-up and continued update from Pivot Trial, we now actually know that the prostate cancer treatment was beneficial with a reduction that meets statistical significance, but not by much, of 0.84 as a hazard ratio, an 8% relative risk reduction of death, and about 1 year of life gained for veterans that were treated with surgery. And again, this was a relatively comorbid cohort with almost an exactly 10-year life expectancy. And again, in subgroup analysis, the benefit was even greater for men that were diagnosed with intermediate risk disease instead of low risk disease. So looking back at the 2012 recommendation from the USPSTF, which was made when we didn't have full maturity in all of these screening trials, we see now that PSA-based screening has cut the risk of metastatic disease at presentation almost in half, where we haven't seen a similar effect with widespread adoption of mammography screening for women with breast cancer. We now have trial evidence to show that it not only prevents prostate cancer mortality, but it prevents overall mortality as well. And that we do need to consider the type of cancer that we diagnose and a patient's life expectancy to really make sure that we're doing a benefit to our patients. So looking back, they estimate that for men that were less than 75 years of age, the decision by the USPSTF in 2012 resulted in a significant increase in men being diagnosed with intermediate or high-grade prostate cancer because PSA-based screening dropped off so dramatically, and a significant increase in the presentation with metastatic disease. And these numbers were even more significant if men were diagnosed after age 75, where you have a doubling of men presenting with metastatic disease at the time of their diagnosis. And so in 2018, the USPSTF actually changed their recommendation, and their recommendation still stands as consider PSA-based screening for men that are 55 to 69 years of age. Do not screen men routinely that are 70 years of age or older. And a lot of this pick of a cutoff of 70 years of age is based on average life expectancy. So you want men to have a significant life expectancy, significant longevity to benefit from prostate cancer screening. And this comes down to the two factors that influence whether or not screening for prostate cancer will work. So one is the cancer biology. We only want to detect prostate cancers that are clinically significant, and many prostate cancers will be very slow or may never progress. And so detecting and treating those cancers is obvious overtreatment and will harm our patients. But for fast-growing prostate cancer that is clinically significant, we would want to detect it in time. The second aspect of this is you want to understand the host that the cancer is growing in and the competing risks of death from other causes and their overall health. So for men that have a very long life expectancy, we may care about fast or slow or even very slow prostate cancer. But for men with a limited life expectancy, we may only care about the fastest growing prostate cancers. So a prostate cancer screening strategy really should be tailored to the patient. We don't want to screen every patient, and we don't want to detect every prostate cancer anymore. And a lot of the talks that we'll hear later on today will be focused on how we can do a better job of understanding which prostate cancers are clinically significant and which patients are the appropriate patients for screening. So in summary, what is the evidence now that we can look back on and say whether prostate cancer screening is effective based on PSA? So we know that prostate cancer screening with PSA reduces prostate cancer mortality from 2 large trials. It prevents metastatic disease from 2 large trials. and that prostate cancer treatment is not likely to be effective or a good choice for men with very low risk disease, but it does show survival benefit for men with intermediate risk disease based on 2 large trials. And again, the treatment of prostate cancer, once detected, can avoid advanced disease and all of the side effects related to treatment of advanced disease. So as we learn from history, what should we do now? Well, I would suggest, and these are the AUA guidelines as well as data presented in the New England Journal, that prostate cancer screening should be considered for interested men age 55 to 69 if they have sufficient life expectancy. Most people estimate that at 10 to 15 years of estimated life expectancy. That screening does not have to be as intense as we originally thought. Perhaps every other year would be a reasonable strategy rather than every year, as we learned from the Plco trial. And we need to understand that if we detect prostate cancer, that prostate cancer is not uniform and that not all prostate cancer needs to be treated. So we need to avoid overtreatment of very low risk or low risk prostate cancer when diagnosed, and really push for patients to understand that if we find low risk prostate cancer, that doesn't necessarily mean we need to progress to the next stage and treat their cancer, potentially causing futile toxicity from their treatment. And thank you again for the opportunity to present, and I'm happy to take a few questions at the end of this talk.
Thank you so much, Dr. Leppert. That was a fascinating discussion. I think to understand where we are now, it's very helpful to see, the historical landscape of how we got here in the first place. So there's a lot of emphasis in primary care about shared decision-making. And just kind of wanted to see your thoughts on shared decision-making in terms of what that means for you. And then also, if you can maybe be also explicit in terms of what are the downsides of PSA screening for the patients clinically when we're discussing the risk of overtreatment. What do we mean by overtreatment here?
Right. Well, that's a lot to consider, but I think you're absolutely right. Shared decision-making is absolutely important. The screening recommendations consider the population as a whole, and the patient sitting in front of you may not be the exactly average man. And so there are reasons to screen more aggressively for patients that have a family risk of prostate cancer, that may have exposures that are relevant. I work in the VA, and we consider exposure to Agent Orange, burn pits, other environmental exposures as important for prostate cancer decision-making. And so those can affect the decision to screen. But screening, this discussion is challenging. And I'm sure in the primary care setting, it's also challenging to block off time to have this discussion that is very nuanced. We spend quite a large amount of time seeing patients in our urology clinics with this shared decision-making approach to decide if they want to have a PSA-based test or if they want to have a prostate biopsy if the PSA is elevated. So the downsides are all of the anxiety and worry that goes into a prostate cancer diagnosis, all of the anxiety or worry, the financial toxicity that goes into a biopsy to evaluate their cancer, or eventually imaging to evaluate their cancer, treatment of cancer, and that all of these treatments have significant side effects. So we worry about sexual function, urinary function, incontinence, in addition to all of the challenges of doing surgery or radiation in general. So this is a very challenging decision for many patients and for many providers. And if we don't have adequate time, it's very hard to do right because it is so nuanced. So this is definitely an area where PSA has been arguably the most important cancer biomarker ever discovered, but also potentially the most damaging when we consider the number of men that have been treated for prostate cancer that may not have needed to have treatment. And I'm really excited to see that our fields are moving away from kind of treating every single person diagnosed with prostate cancer and thinking more carefully about what cancers actually need to be treated.
Great, thank you, Dr. Leppert. A couple questions about family history, and I know we'll get into some of this with Dr. Cooperberg's talk coming up here pretty soon too. But how does family history affect your recommendations for PSA screening?
Yeah, I think this is very similar to other types of cancer. I mean, if I hear from a patient that their father passed away from prostate cancer, they have brothers that have been diagnosed, treated, or even passed away from prostate cancer. So these first degree relatives, I think, are very important. Family history, though, is not limited to just prostate cancer as a history as well. We now have discovered links between prostate cancer and other cancers, between BRCA1 and BRCA2 genes is an example of familial syndromes that can include prostate cancer. So those decisions are important. There's a joke in prostate cancer treatment that was made by Dr. Walsh, who was kind of the pioneer of modern surgery for prostate cancer, which is he would treat any man with prostate cancer who's brought in by his father. The idea being that if you have sufficient life expectancy in your family history, that may be a reason to consider treatment regardless of the age, that chronological age is just a number. But this also applies to prostate cancer decision about screening. So if your father was diagnosed with prostate cancer at age 90, that's very different than if your father passed away from prostate cancer at age 55. And so understanding how all of these family histories manifest and the severity of disease that manifest it can be important and sometimes difficult to figure out, because with that peak in PSA screening, many people were diagnosed in the early 90s with low risk disease and had treatment, maybe even side effects that we might not treat the same way today.
Dr. Lippert, is there ever a PSA level that you would say this is sufficiently low that we don't need to worry about a prostate cancer risk for the rest of this patient's life?
Oh man, I wish there was. One of the benefits of the Plco trial was that everybody got a PSA and everybody got biopsied. And it was surprising that even men with very low PSAs did have an incidence of detection of clinically significant prostate cancer, even at low PSA numbers. And so that's where some repeat PSA values can be helpful. So if you start with a low PSA, that's very reassuring, that's great news, but it may not be enough to kind of ignore PSA screening forever. And so you can look at serial PSAs to see the change in the PSA over time, how fast it's going up, if it goes up. If it fluctuates going up and down would be more reassuring than if it had kind of a very steady rise. More likely to be something like BPH at that point than prostate cancer. So I think we can say that in some generalities, lower is better, but it's not always as simple as just saying it's low now so we can stop.
Great. And then just a question about the earliest age for screening with the family history.
Yeah, so most groups do not recommend screening below age 50, certainly below age 40, depending on the group that have kind of presented their recommendations. And so I think most people consider starting as patients reach the 5th or 6th decade of life. And again, it comes back to life expectancy as well. I mean, there are many men that may have competing risks of mortality at age 60 that may not be appropriate for prostate cancer screening. So again, it comes down to trying to really see the patient in front of you and do the best thing for them.
All right, maybe one last question that we have here. Can we review what constitutes an alarming rise in number between a biannual testing for screening if still low?
Yeah, the velocity, PSA velocity that's often considered concerning is 0.75 as a rise per year. So I think if you see a PSA that goes from 2 to 4 in 2 years, that would be enough to consider repeating the PSA or even consider referral for an elevated PSA, even though the absolute value of PSA still falls within the normal range.
Great. Thank you so much, Dr. Leber. This has been a very informative talk, and we'll move on to our next speaker, and Dr. Kaki will introduce. Thanks.
Thank you again.
Great, thank you. So our next speaker is Dr. Jeffrey Son. Dr. Son is an associate professor of urology at Stanford School of Medicine. He specializes in treatment of patients with prostate and kidney cancer and has a particular interest in cancer imaging, MRI, ultrasound, fusion, targeted biopsies, and prostate cancer focal therapy and robotic surgery for prostate and kidney cancer. He was a Stanford principal investigator for a major clinical trial using MRI-guided focused ultrasound to treat prostate cancer. And the goal of the trial was to treat prostate cancer with fewer side effects than surgery or radiation. Dr. Son today will be discussing the latest in diagnostics for prostate cancer with a focus on imaging. Dr. Son.
Thank you. And excited to be here to talk about prostate cancer imaging and the way that that has improved the way that we diagnose prostate cancer. I have no relevant disclosures for this talk. And I want to go over a couple of primary goals. One is to help you to understand how MRI has improved prostate cancer diagnosis. And then I will also briefly touch on a new type of PET scan called psma PET scan that works especially well for prostate cancer that was recently approved. And finally, talk briefly about image-guided treatment with an approach called focal therapy. But let's start with imaging. For decades, really the only imaging that we had available for prostate cancer is transrectal ultrasound. You can see a sample image here. It does a nice job of telling us where the prostate is, but performs very poorly in trying to identify individual foci of cancer or areas of suspicion for biopsy. And because we didn't have any good imaging to tell us where to look, the traditional method of prostate cancer diagnosis evolved using ultrasound to find the prostate, and then randomly placing usually 10 to 12 needle samples throughout the prostate, hoping to find prostate cancer. And while this finds many prostate cancers, as one might imagine in this image blind approach, there are significant limitations. For example, we can miss significant prostate cancer just due to sampling error. The needles just happen to miss the area of tumor. Conversely, this can contribute to this problem of over-detection, where by chance a needle happens to hit a very small area of often low-grade prostate cancer that the man would have been better off not even knowing about in the first place, but because he had a diagnosis of cancer for years, often led to treatment and side effects. So this approach has significant problems. Fortunately, we have better imaging available to us now in the form of MRI. As you can see in the image on the right, MRI now allows us to see what is going on inside the prostate, to find specific areas that are suspicious for cancer, so that we may be able to target a biopsy at that area and get more active information or accurate information to act upon. So let's address two questions. Number one is, should men be getting an MRI prior to biopsy? And number two, well, what are we going to do with the result of that MRI? So should we be getting MRIs? The quick answer is yes. This is a new guideline, relatively new guideline from the NCCN, the National Comprehensive Cancer Network, in which the recommendation now is a man who has an abnormal PSA ought to undergo a prostate MRI before consideration of a biopsy. Now, what is the evidence upon which this recommendation is based? There are a lot of studies that have been published. I'm going to focus primarily on two. This one here is the first. This is referred to as the PROMISE trial. This was a study that was done in the UK and really a remarkable study design. They enrolled 576 men who had a high PSA or otherwise were going to undergo a biopsy. But first they had an MRI that was done. Patients and clinicians were blinded to that MRI. The patient then underwent a standard ultrasound guided biopsy, as well as a template mapping biopsy, which is an extremely intensive biopsy that was done in the operating room. They would take 50 plus cores as a way to establish a gold standard about whether cancer is present and what is the grade of that cancer. And by doing this in all patients, it allowed for the direct head-to-head comparison between the performance of MRI versus transrectal ultrasound guided biopsy in the detection of significant prostate cancer. This study showed us that the sensitivity of MRI was far greater than that of transrectal ultrasound biopsy. So a 93% sensitivity for significant prostate cancer compared to just 48% for an ultrasound guided biopsy. So much better for MRI. As might be expected, the specificity of MRI is much lower because there are sometimes suspicious areas that turn out not to be cancerous. But the biggest takeaway from this is the sensitivity was quite high, and it allowed between 25 and 30%, or would have allowed between 25 to 30% of men to avoid a biopsy in the first place on the basis of a normal prostate MRI. Due to changes in clinical guidelines and some of the evidence like the study that I just presented, we have seen a significant uptick in the use of pre-biopsy MRI. In 2010, only 1% of men were getting an MRI before their biopsy. By 2015, that number increased to 10%. Now, this publication, this figure is from a publication from just last year, but they only had data going up to 2015. And undoubtedly, over the last 7 years, there's been further substantial increase in the use of MRI prior to prostate biopsy. Like many things in medicine, we see variation and disparities. Here are just a couple of examples. We see a map of the US, and what we notice here is that there are significant differences across states in the use of pre-biopsy MR. In California in green, we see that 14% of men were getting an MRI prior to their biopsy, while in many of the Great Plains states, for example, no men were getting an MRI offered to them prior to prostate biopsy. This is from another study published last year that looks at this trend again of use of pre-biopsy MRI over time. We can see white men are represented in orange, black men in blue, and we see that white men were more likely to be offered an MRI prior to biopsy. So what do we do with this information? If an MRI is normal, much of the time or most of the time, we don't need to do a biopsy. But if the MRI is abnormal, how do we use that information to help us to make a diagnosis of prostate cancer? We use a relatively new technique that's been available for the last 10 years or so called MRI ultrasound fusion targeted prostate biopsy, a mouthful. This is what this looks like in practice. So a man will undergo an MRI, and then the radiologist will interpret that MRI, finding any areas of suspicion. They'll also mark out the edge of the prostate in multiple different planes, which allows for the creation of a three-dimensional model of the prostate based on MRI. At the time of the biopsy, the urologist will do the same thing. We'll mark out the edge of the prostate in multiple different planes using ultrasound. This generates a three-dimensional model of the prostate based on ultrasound. And using a fusion biopsy device, we can line up these two models such that we're able to target things under ultrasound guidance, even if they're only visible on MRI. And this targeted biopsy approach has been shown in many studies to improve the detection of significant prostate cancer. This is the second major study that I want to discuss this morning. A randomized trial enrolling 500 men. Men were randomized either to an MRI, either with or without targeted biopsy approach, versus the conventional approach in which all men would undergo an image-blind ultrasound-guided biopsy. The study was conducted at 25 centers across 11 countries. Centers were recruited based on excellence. You can see here that the average radiologist was reading 300 prostate MRIs a year, which is quite a lot. So you have to be good at this to get good results. And this is what this study showed. This is the study schematic. On the left, we see the control arm. These were men randomized to undergoing an ultrasound-guided biopsy. On the right, in green, we see this, what they refer to as the precision paradigm, which means rather than going straight to biopsy, a man would first get an MRI done. If the MRI was normal, he would not have a biopsy, instead just be followed with PSA. Conversely, if the MRI was abnormal, he would go on to have an image-targeted biopsy where a few cores were aimed at the area of suspicion. What this study showed was similar to the prior study. Between 25 and 30% of men avoided a biopsy altogether on the basis of a normal MRI. And even after that, they still found more significant prostate cancer in the MRI and targeting arm than in the conventional arm. So higher rates of detection of significant cancer, the ones that we want to find, and lower rates of detection of low-grade insignificant cancer, which is the ones we don't really want to find. So very strong evidence of the value of this approach. I would be remiss if I don't briefly mention some of the limitations of prostate MRI. There are a number of studies that show significant variation both in image quality and in the quality of the interpretation by different radiologists. So it's important in men getting one of these MRIs. Ideally, it ought to be done in a center that does a lot of this, that does a good job acquiring these images as well as interpreting the images. Another consideration is that while most significant prostate cancers show up on MRI, some do not. So there will be some patients, particularly those with a very elevated PSA, for example, in whom even a normal MRI may not be enough to say, no, you don't necessarily need a biopsy. But again, most of these cancers should be visible. And in particular in the US, prostate MRI and MRI in general can be quite expensive. The center may charge $5,000 for a prostate MR, while in Europe or Australia, on the same machine, that same scan may go for $500. So that's the end of the MR section. I also want to touch on a couple of additional topics. The first one is a PSMA PET scan. PSMA for prostate-specific membrane antigen. This is a newly approved type of PET scan that works very well for prostate cancer. And that's because it's going after a protein that's on the cell surface of prostate cancer cells that's way overexpressed in prostate tissue and especially prostate cancer. It's also present both in the metastasis as well as the primary tumors within the prostate. This was recently approved by the FDA for two specific indications. The first is for staging of newly diagnosed high-risk prostate cancer to try to look for metastasis. And the second is for evaluation of biochemical recurrence, which means men who have been previously treated for their prostate cancer and now their PSA is rising, and we're trying to figure out where is that coming from, where is the cancer, so we know what to do for a secondary treatment. Just to give it an example of what this looks like, this is a figure from a paper that was published last year. These are two images from the same patient. We can see on the left-hand side a bone scan. This patient had one area of a subtle abnormality on the bone scan. He then underwent a PSMA PET scan that we can see in the middle of the screen here. And all those little small black dots represent prostate cancer metastasis. So we can just see how profoundly the bone scan misses so many of these areas of metastasis in this patient that truly does have numerous bone metastasis related to his prostate cancer. So PSMA PET scan is a better staging imaging test than conventional CT and bone scan. Now, I mentioned that PSMA PET not only finds metastasis, but it can also find the primary tumor within the prostate. And this is an example of that. You can see here a prostate MRI in a patient that has a fairly subtle lesion that the yellow arrow is pointing to here. So it's visible, but not super obvious. This patient then underwent a PSMA PET MRI, and it's no longer subtle. This tumor lights up like the sun. We can very clearly see this cancer present within the prostate. So what about treatment? How can we use this information? So far, we've been focusing on diagnosis, but can we use this improved imaging to improve our treatment? And this is critically important because, as Dr. Leppert mentioned, side effects are a big deal with prostate cancer treatment. Just as one example from population-based studies, we see that roughly 50% of men who undergo surgery or radiation have new onset erectile dysfunction. Side effects related to treatment are one of the major factors that have contributed to decreases in screening for prostate cancer in the first place. So the goal here is to use advances in imaging to bring new treatment approaches with fewer side effects. And this is very much in line with this idea of personalized medicine, or treating patients differently based on differences in disease characteristics. What we see here is two separate patients, both of whom underwent a radical prostatectomy for prostate cancer. The cancers are outlined in green. What we notice on the left-hand side of the screen is a fairly small amount of prostate cancer in one spot. And on the right-hand side of the screen, a patient whose prostate was chock full of tumor. And personalized medicine suggests that we should consider treating these patients differently. And this is where this idea of focal therapy comes in. Focal therapy is the targeted destruction of cancer while preserving normal surrounding tissue. So in this case, trying to destroy that portion of the prostate that's involved with cancer. This has been also referred to as the male lumpectomy. It has been shown to reduce side effects from prostate cancer treatment with good cancer results, at least in the short to intermediate term. and at the same time preserving the option for surgery or radiation therapy should focal therapy fail. So let me show you an example of what this looks like in practice. This was a patient that was treated in a multi-center clinical trial at Stanford using a technique called MRI-guided focused ultrasound, which is killing this cancer with heat generated by ultrasound. We can see the yellow arrow pointing to the black spot on the prostate MRI, showing the site of cancer. This was an immediate pre-treatment MRI, and post-treatment, post-contrast MRI, we see no more blood flow to that area of the prostate. That area of the prostate's dead. And we purposely treat an area that's larger than the black spot in the MRI because we know that the cancers tend to be larger in reality than they appear to be on MR. But the rest of the surrounding tissues are all preserved here. Going back to this image again, so a prostate MRI that's done, the cancer is being pointed out to with the yellow arrow. PSMA PET scan done prior to treatment shows the cancer very clearly. After treatment with MRI-guided focused ultrasound, we see 6 months later, most of the prostate looks identical, except for that cancer is now gone. So that area of the cancer is gone, a biopsy confirmed no prostate cancer. And importantly, this patient who had excellent sexual function pre-treatment continued to have that same level of excellent sexual function post-treatment. So that's an anecdote. What about the larger evidence? This is the last study that I want to mention. This is a multi-center study conducted in the UK using high-intensity focused ultrasound, or HIFU, and following patients out to 5 years. 625 patients were enrolled. What they found after treatment was low rates of side effects. So only 2% of patients had to even wear a pad for urine leakage, so rare urine leakage. And the success rates were very high. Even 5 years later, the success rate of 88%. Most of those failures just meant that the patient had to go on to have surgery or radiation at some point, which is the same treatment that all of these men would have had prior to the advent of this HIFU focused ultrasound. So the conclusions of this trial were that this treatment, HIFU focal therapy for select patients, this is not for everybody, but for select patients with significant prostate cancer, has good intermediate term cancer outcomes and very low risk of side effects. Last slide here. So take home points. Number one, should men be offered an MRI before biopsy? I would say the answer to this is yes. This is now emerging in clinical guidelines, and there's strong, even level 1 medical evidence in the benefit of this approach. Can we skip biopsy if MRI is normal? In most cases, yes. However, it is important to consider other risk factors. For example, a patient with a normal sized prostate and a PSA of 15, whose MRI is read as normal, we may still want to consider a biopsy, recognizing that not all prostate cancers will show up on MRI, although most do. How to use PSMA PET scans. The FDA indications are for initial staging and for testing for recurrence. And then finally, what is image-guided focal therapy? This is this idea of treating the tumor and not the entire prostate, with the goal of reducing some of the side effects of prostate cancer treatment. Thank you. And happy to take any questions.
Thank you, Dr. San. Excellent talk. Very cutting edge stuff, very exciting. I'll start out with a question about how do you recommend deploying this, or how are you doing this at Stanford? Are the primary care physicians ordering an MRI once they see an elevated PSA, or is that something that the urologists do after for initial consultation?
It's a bit of a mixture. I would say most often we are seeing the patients with the elevated PSA and then making the decision about who ought to get an MRI or not, although occasionally some of the primary care providers will be ordering the MRI and will send patients to see me with the MRI. I think I don't get an MRI in everybody because some men may have a shorter life expectancy. They may have a marginally elevated PSA and we just want to track that for a while before considering it. So it's not a reflex thing that every PSA above 4.0 generates an MRI, but everyone does have the ability to order the MR. Some of the hard part can be, what do we do with the results? A lot of times there can be false positives that can make the patients very nervous. So I'm totally fine seeing these patients with a high PSA to help them decide in the MRI and then to walk them through the result and what we ought to do next.
And if a patient had a negative biopsy before getting an MRI, but has an elevated PSA, should they have an MRI and get a repeat biopsy?
Yeah, I think that it's important to wait. So if occasionally I'll see a patient who had a negative biopsy, they come to see me 3 weeks later and saying, I'm nervous about this, what should I do? So we don't get an MRI immediately because some of the bleeding that can take place or inflammation can mask any potential cancer. So we'll always wait at least a few months, if not much longer. For someone that I see that, say, 2 years ago had a biopsy because his PSA was 6 and it was negative, and now the PSA is 9.5. Absolutely, MRI plays a very important role in that setting to help us find what areas are we worried about, where we want to target. Very often we'll find a cancer up in the anterior prostate, which is not routinely sampled with a regular ultrasound guided biopsy, and the MRI will alert us to that so we can specifically target that area.
The case you shared with us about the PSMA and the MRI and the HIFU is a pretty instructive case. There's a question about why not use PET PSMA instead of MRI for screening?
I think so. So PSMA PET is very, very new. This was just within the matter of the last few months, widely available. So I do expect that the utilization of PSMA is going to change. It's going to evolve over the next 5 to 10 years. So it's hard to know in what settings it will be used. At present, it's not one of the recommendations it's not FDA approved for that setting. In practice, I think it likely will be the case that we will be doing that on occasion, but probably in select patients where there's still some question after the MR. PET MR scanners are not widely available. Most places don't have them. PET CT lacks the anatomic detail that we need to know where we're going to be targeting and what we're dealing with. So I think for the time being, we're likely looking at MRI, perhaps with a combination of PSMA down the line if there's still uncertainty.
There's a lot of questions coming in about PSMA. It's a very exciting new technology. Can you talk about if there are any contraindications to PSMA PET and if Lupron has any effect on what you see with PSMA PET results?
So I think you as a medical oncologist will deal with this to some degree also. I think that PSMA can work quite well in people who have not been on any androgen deprivation treatment. So that's the setting that I am typically seeing patients. It also can work quite well for men with castrate-resistant prostate cancer, so that they've been on androgen deprivation to lower the testosterone. Now the PSA is starting to rise. PSMA PET is good in that setting. It seems to be not as good shortly after the initiation of androgen deprivation treatment, that may lead to false negative findings. So it's nice if we're considering a PSMA to do it before initiating androgen deprivation to figure out what we're looking at. Apart from that, there's not a lot in the way of contraindications, I would say, for getting it. This is just like the FDG or other type of PET scans that we commonly order. And anybody that can get one of those PET scans can get a PSMA PET scan that's done. It's just a different tracer.
Yeah, I agree with you. I think there are some convincing case series, especially in that sort of biochemically recurrent patient. If you start an ADT, either with microlumide or Lupron, before getting a PSMA PET, there can be some false negatives. There's also a question, do you think PSMA PET should replace conventional imaging for patients for staging?
I think so. I think that payers can take longer to come along with some of the guidelines that are out there for what should we be doing for imaging. So we still get a significant number of denials. This will probably go down over time because there are clinical guidelines that say that you don't necessarily need to get a bone sand and a CT scan before going on to get a PSMA PET scan. Just the performance characteristics are much better. So if I see a patient with newly diagnosed high-risk prostate cancer, I typically try to get a PSMA PET CT rather than getting a bone scan and a CT scan.
I know this was a topic of much debate at ASCO GU this last year, so it's an interesting field that continues to evolve. Another question was about flucyclovine PET and then gallium and PYL PSMA PETs, and where do you see the role for the flucyclovine PET in the face of these other PSMA PETs?
So flucyclovine PET, also called Axamin PET typically, is another PET tracer that's been around for a few years, not a long time, but longer than PSMA. There's a lot of excitement about doing a better job of finding metastatic prostate cancer. It does not, in some situations, can be complementary to PSMA PET scan, but the performance characteristics are just not as good. So I think that in patient where we're suspicious about for prostate cancer, if we have access to both, I think it's better to start with the PSMA PET. In places where you may only have access to flucyclovine PET, there may still continue to be that role, but PSMA does perform better. And then in terms of gallium or PYL, there's a number of different names that are available, and some places may have access to multiple, other ones may only access to one. So depending on where you work, there may have different names for these, but PSMA is just a general blanket term for this type of PET. There are a few different approved agents that are targeting that PSMA in the cancer cell surface.
And then I'll finish up with a couple questions about sort of focal therapy. There's a question about in younger patients, is it appropriate, especially or with tumors close to the transitional zone? Is that something that can still be considered?
Yeah, there's no hard and fast contraindications. I think one of the big things that I want to mention is that for men with low-grade prostate cancer, I don't recommend any treatment, including focal therapy. So a Gleason score of 3 + 3 = 6, those are patients that I put on active surveillance and monitor them. For men with particularly high-risk tumors, a lot of the Gleason 8s and certain Gleason score 9 and 10. So the highest risk prostate cancer, I think focal therapy is less attractive for them too, because we're not doing anything with lymph node staging or treatment. It's really for the intermediate risk tumor, which is the preponderance of prostate cancers that really ought to be treated. Focal therapy is in play, I think, as an option for them. This can be a good treatment for young men, who are often some of the men who are the most motivated to preserve sexual and urinary function. So I don't say, I never tell a man, no, you're too young to have focal therapy. I think the bigger issue is, can we prove to ourselves, based on the combination of imaging and biopsy, that we know where the cancer is located? Ideally, that there's only one spot of clinically significant prostate cancer, as opposed to multifocal disease that's scattered throughout the prostate. In those cases, focal therapy is probably not as good. Most of these are in the peripheral zone of the prostate, but we can treat things that are approaching the transition zone or in the transition zone, because while I mostly mentioned HIFU, high intensity focused ultrasound, there are a variety of focal therapy treatment modalities that are available. At Stanford, we offer several of these, including ultrasound guided HIFU, MRI guided HIFU, MRI guided cryoablation, transurethral ultrasound ablation, and there are a number of others that are available at other places too, that you can pretty much reach most areas in the prostate.
Great. Thank you so much for that excellent talk. I'm going to hand it back over to Dr. Shah to introduce our next speaker.
Great. Thank you so much, Dr. San. That was terrific. Our next speaker is Dr. Matthew Cooperberg, who unfortunately cannot join us live, but has pre-recorded his presentation. So we'll be viewing that here shortly. Dr. Cooperberg graduated from Dartmouth College and earned his MD and MPH degrees from Yale University, and completed residency in urology and fellowship in urologic oncology at University of California, San Francisco, UCSF. At the end of his training, Dr. Cooperberg joined the faculty at UCSF, where he is now Chief of Urology at the San Francisco VA and the Urology Co-Leader of the Prostate Program at UCSF. He also holds a secondary appointment in the Department of Epidemiology and Biostatistics. He is actively engaged in research approaching the challenges of prostate cancer from many interrelated angles, from molecular analyses to health system-wide research. He has written or contributed to over 400 research articles. In 2015, he won the AUA Gold Cystoscope Award and in 2016 was awarded his first R01 grant as a principal investigator from the National Cancer Institute, the NCI. This was work to develop and validate novel microRNA-based biomarkers signatures for refined prostate cancer prognosis. Dr. Cooperberg will be discussing genetics and genomics in prostate cancer.
Hi, I'm Matt Cooperberg from UCSF, Department of Urology and Epibiostat, just up the street. And it is a pleasure to share with you today an update on the genetics and genomics of prostate cancer, both before and after diagnosis, in context of the ever-evolving space of prostate cancer biomarkers. In terms of disclosures, I do work with some of the companies whose tests we'll be discussing today. And it's important to frame this conversation in light of what is the ongoing controversy about screening, because at the end of the day, the controversies about prostate cancer screening and management have all been about the heterogeneity of the cancer. And this is where the genetics and genomics are starting to shed some additional light. And there's a great cartoon and concept that was published by Ian Thompson, who's one of the urologic oncologists at UT Southwestern, and Laura Esserman of the breast program here at UCSF a number of years ago in JAMA. The concept being, if you screen for any cancer, whether this is colonoscopy for colon cancer, mammography, PSA screening for prostate cancer, if you screen on a given interval, ultimately the patient will either reach the far right of the cartoon here, where they died of some other cause, usually cardiac disease, or they get to the top where they've actually died of the cancer. And the concept here is, even with aggressive screening, there are many tumors which we never find. We know these so-called autopsy tumors are highly prevalent in the case of prostate cancer, and we don't find many of them. This is fine. We don't need to find them. They're completely indolent. Then there are many cancers that we can find while they are confined to the prostate. We can so-called cure them with surgery or radiation or other treatments, but had we never found them, they never would have progressed to cause any sort of symptom or threat to life. These are the overdiagnosed cancers. Then they're the ones that we can find when they're confined to the prostate. If we did not find them, they would progress to lethal disease. And then finally, there are the rare cancers where the PSA is 0.7, then it's 1.2, and then it's 4. These are the so-called interval cancers. These are fortunately rare in the case of prostate cancer. And our attention has been all about how many turtles we've squished in the course of chasing the rabbits, because it is in the course of chasing the rabbits that we've driven down the mortality rates by nearly 50%. So with this background, let's dive in. We use the term genetics and genomics not quite interchangeably, and it can be a little bit confusing. Just by convention, when we talk about genetics, we're typically talking about germlines. This is, of course, the inherited DNA, which we can assay by either a blood test or saliva test or cheek swab. Genomics typically refers to acquired alterations in the DNA, either mutations or dysregulation of expression. And this is a feature of the cancer itself. And we assay this either by looking at the tumor tissue or increasingly with attempts at doing so-called liquid biopsy. There's been a lot of progress in terms of the understanding of germline risk and prostate cancer in recent years. In terms of the identified mutations, a lot of the focus is on the DNA repair path mutation complex, in particular the BRCA mutations, BRCA1 and 2, with BRCA2 being the single gene most strongly associated with prostate cancer. ATM and CHEK2 are also in this category. But in some, these account for a relatively small proportion of inherited genetic risk in prostate cancer. So from patients who progress to metastatic disease, we can find one of these mutations in the germline in somewhere between 7 and 16% of patients, depending on which study we're looking at. For high-risk localized disease, it's somewhere between 6 and 9%. Lower rates for localized disease, low-risk localized disease. And in fact, these rates are not so different from the 3% which have been found in men without a known diagnosis of prostate cancer. But the fact remains that for prostate cancer being one of the most heritable cancers in terms of linkage analyses, we can explain a relatively small proportion of inherited risk with the known mutations. The majority of inherited genetic risk still reflects unknown, likely polygenic risk factors. We do know that men who develop prostate cancer in the setting of BRCA germline mutations do tend to be more aggressive. There's a 3 times increased odds of progression to metastatic disease and cancer mortality from high-risk localized disease among men with these mutations compared to those who do not have them. And the guidelines are increasingly clear in terms of which prostate cancer patients should consider germline testing for BRCA and related mutations. So obviously, if there's a family history in that family already of something like a BRCA mutation, Ashkenazi Jewish patients, those with a strong family history. And here it's important to emphasize the word strong. You know, every man's got a cousin or an uncle or a distant relative who had prostate cancer. Here we're really looking for first-degree relatives, for those who had aggressive cancers, certainly anyone with early prostate cancer death in the family, or if there's more than 3 cancers in the whole spectrum of BRCA-associated cancers. So that includes breast, pancreas, ovarian, colon, and urothelial. But again, these rare mutations that we're looking for really only tell part of the story, and there's an increasing interest in also looking at the broader spectrum of inherited risk by looking at SNP profiles. And there are a number of polygenic risk and polygenic hazard scores which are now out there, which really modulate the, which explain a significant proportion of risk beyond the known single gene mutations, and actually can modulate even the positive predictive value of an early PSA screen. So the PPV for an elevated PSA, this is over the old threshold of 4, ranges from only about 7% to nearly 25%, depending on where your genetic risk falls. Most of us are not suggesting that any of these tests be done before PSA, but they could potentially help us interpret PSA in men with borderline tests. Likewise, these polygenic risk scores can further modulate the implications of a known BRCA or related inherited gene. This is the odds ratio for high-grade cancer by PRS risk decile again, and you can see these risks shift very dramatically upward for having a BRCA or related mutation if you are in the higher end of the risk category by a polygenic risk SNP score. And these are increasingly going to be available for patients because they're going to be baked in to tests like the Invitae or 23andMe. And ultimately, these will help us guide men along the continuum of discussion from should they get a PSA test on to what do we do with the cancer after diagnosis. There's one specific question which has caused some controversy recently, which is, can men with BRCA mutations safely do active surveillance, meaning not treating immediately when they are found to have low-risk disease? There's a number of treating urologists and radiation oncologists and medical oncologists out there who are of the opinion that if you've got a BRCA mutation, you really should go straight to treatment no matter what the tumor characteristics are at time of diagnosis. The best data for this come from the Hopkins cohort so far, which do show an increased risk of reclassification to higher grade disease by 5 to 10 years out from diagnosis. But the fact remains that at 5 years, even men with mutations, only 50% of them have actually gone on to reclassify. So I am firmly in the camp that would say these men need close surveillance. They need to be counseled that eventually they may need treatment, but there is still no imperative to treat immediately when everything else about the cancer remains low risk. And in the setting of advanced disease, some of these mutations are becoming actionable as well. Patients with germline or somatic, meaning in the tumor, alterations in the BRCA and related genes may be particularly well suited for treatment with PARP inhibitors and maybe for platinum chemotherapy. Those with mutations in other aspects of DNA repair might be particularly well suited for immune checkpoint inhibition. This is all very early days, but we're very much entering the true era of precision personalized medicine in the case of prostate cancer. So what about somatic genomics? Well, we can break this up into pre and post-diagnosis testing. And the pre-diagnostic considerations really need to be understood in context of the fact that PSA is probably the best liquid marker we have ever had in oncology. We just haven't used it very well, especially as a screening test. If you look at the history of PSA screening since the 90s, we have tended to overscreen old, relatively frail men. We have underscreened the young and healthy men who benefit the most. When we find prostate cancer, historically, we overtreated the low-risk disease and undertreated high-risk disease. And we've used PSA with an incorrect, inappropriate threshold of 4.0. Despite all these flaws and limitations, we have driven down prostate cancer mortality rates by over 50% during the PSA era, and at least half of this decline is more or less directly attributable to early detection and better treatment for aggressive disease. So imagine if we use PSA better. And I'll make a couple comments in terms of how we can use it better. So the bar is actually quite high to prove that we can do better by incorporating genomics or other biomarkers. And the first point I want to make here, I said 4.0 is an inappropriate threshold. The reason we wound up with that threshold is that PSA was developed among men mostly in their late 60s and early 70s in whom BPH is extremely prevalent and is an alternate competing source of PSA elevation. PSA, of course, is prostate-specific antigen. It is not prostate cancer-specific antigen. Some wonderful cohort studies published over the last 10 years have really made clear that when we use PSA earlier, it's a much more reliable and more accurate test with much lower thresholds. So, for example, if the PSA is less than 1 by age 60, which it is for the majority of men, you're pretty much done. Prostate cancer risk over the rest of your life falls to less than 0.3% mortality risk. And 90% of the deaths occurred in men with a PSA over 2 at age 60. We can go back even further in time in age and look at men in their late 40s for whom the median PSA is 0.7. The top quartile is defined by 1.1, the top decile by 1.6. Pretty much all of the distal mortality events, and these are quite distal, we're seeing these at 15, 20, 25 years after the PSA screen, all of the action is in the top quartile and the top decile. So with a simple early baseline test with a threshold around 1, you can basically take 75% of the population out of the worry pool for prostate cancer risk, more or less forever, certainly for decades to come. And it makes an extremely good initial screening test when it's used in younger men. And there've been a number of other cohort studies which have shown the exact same thing. This is in cohorts of predominantly Caucasian and predominantly Black men in the United States, as well as other cohorts in Europe. Very consistently, the median is around 0.7 for men in their 40s, 0.8 for men in their 50s. By the time you get to 60, it's pushing around 1.0, extremely consistent across countries and race groups. So we can use PSA much more intelligently, and this is a protocol which we have now implemented at UCSF after a 2-year conversation with primary care leadership, which was really a wonderful engagement. Our EPIC instance now pops up a health maintenance banner arguing or suggesting either PSA screening or documentation that shared decision-making has occurred. The man does not want to test in between the ages of 45 and 75, with the PSA less than 1, clearing the reminder for at least 5 years. For values 1 to 2 for younger men, 1 to 3 for older men, there's the option of rechecking the PSA 6 to 12 months down the road versus early referral. And for those over 2 in the younger age, over 3 in the older age half, recommending referral. Referral, not biopsy, because we are now using genomic testing and other tests, as well as imaging like MRI, to help make better decisions about which men need to go on for biopsy. And we now have more biomarkers than we honestly know what to do with in this space. The ones which I'll focus on, which are in this genomic category, are mostly urine tests, PCA3 and its related scores, and then others called Select and ExoMDx, which I'll talk about going forward here. Now, even before we get to these, though, it's also important that we not consider PSA in a vacuum. PSA should be considered in light of other risk factors like family history, DRE findings, prior biopsy history, et cetera. And there are terrific online calculators, which can be very useful for decision-making at the point of care. I use the one on the left here, the prostate cancer risk calculator, all the time in the clinic to help men who are sort of borderline decide whether or not they want to go forward with biopsy. And, you know, let's say this was a 7% likelihood of high-grade cancer here. This is the only ones we really worry about. The low-grade cancers, we don't necessarily need to find, and we counsel men in advance of the biopsy, ideally in advance of the PSA, that if we find a low-grade cancer, it does not need immediate treatment. But a man can, you know, 2 men may face the same risk of high-grade cancer. One may choose to get a biopsy, one may choose not to. Those are both well-educated. Those are both good decisions, as long as they are well-educated decisions. Now, for men that are borderline, we now have a number of tests available. PCA3 was the first. This is the full-length mRNA, a non-coding mRNA derived from prostate cancer cell tissue, which is analyzed in the urine after a digital rectal exam. It's been around for a number of years, never quite succeeded, partly because it wasn't well calibrated for high-risk disease diagnosis specifically, and partly because all the testing done on it tried to work with a single threshold of 25 or 30, and really never quite worked out. The best study here looked at it with 2 different thresholds, and this is where it has worked the best. A lot like PSA, there's a low threshold below which PCA3 has a very good negative predictive value, a high threshold above which it has a very high positive predictive value, and then there is a gray area in between, which is a lot like the way PSA works. Excellent negative predictive value below 1, excellent positive predictive value above 10, and then a gray area in the middle, which is what we're sifting with these secondary tests. So PCA3 has evolved, and I'll come to that in just a minute. In the meantime, we have, this isn't quite in the category of genomics, but we do have 2 tests that substratify the PSA into different subcategories of PSA, bound and unbound, as well as its isomers and some of the cousins like HK2. So one assay is called 4K, the other is Phi. These are both looking at these isoforms of PSA and related molecules. And these both do a good job in improving the AUC curve characteristics over PSA alone in the context of a multivariable model, whether we're looking for all prostate cancer or high risk disease over on the right. And these are pretty straightforward blood tests, which are now broadly available. SelectMDx is another post-DRE urine test, which looks at two different genes, HOXC6 and DLX1. Again, full-length mRNA transcripts. This one, again, does a very good job improving the AUC over a full multivariable model based on PSA alone, or in this case, based on PSA plus PCA3. It does a significantly better job than either of those. And this is one that we've used quite a bit at UCSF. It has an excellent negative predictive value for detection of high-grade disease, up to 98%, and is a great rule out for men who have a marginal or even elevated PSA. Now, ExoDx is a relatively new one that incorporates PCA3 as well as TMPRSS-ERG fusion, which is a common fusion that we see in about half of all prostate cancers. The difference here is this is measuring the RNA in the exosomal component of the urine. And what this means is the patient does not need a DRE before the urine is obtained. This is very important, specifically in the COVID era, because the company came out with a home kit. So we can, with telehealth visits, have the patient sent a home kit. They can just pee in the cup and return it to the company, and we get the report without the patient even needing in-person contact with the lab, let alone with the clinic. And this one, again, works quite well at improving the ROC curve characteristics over the traditional multivariable models alone. So all of these do quite well with negative predictive values in the 95, 98% range. They actually do better than MRI as a secondary rule-out test. And we're actually starting to explore whether these can even be used as reflex tests in the primary care setting. So finally, post-diagnosis. Here we're using this to refine the conversations that we have with men after diagnosis, where we know that we need to stratify men in terms of risk to help get them onto the correct treatment path. Active surveillance for low-risk disease, early local treatment for high-risk disease, multimodal and systemic treatment for men with the highest risk cancers. And again, many markers out now. Most of these are based on prostate cancer tissue analysis, doing either RT-PCR or whole transcriptome analysis of the prostate cancer tissue. And one important point here, again, just like we can't ignore PSA and family history and everything that we knew pre-diagnosis, post-diagnosis, we need to think about genomics in the context of everything that we know clinically. And we can do a very good job with standard information like Gleason score, which is how the cells look under the microscope, the grade, the PSA, the number of cores involved, et cetera. We have a 1 to 10 risk stratification system, which we've published and validated over the last 15 years all around the world, called the Capra score, which can stratify men with 85% accuracy from low risk to high risk in terms of long-term cancer mortality. So there's still this line, even the 2018 US Preventive Services Task Force C recommendation for screening, that we cannot tell indolent from aggressive prostate cancer. That is nonsense. We have not always done a good job identifying the right patients for the right treatments according to risk, but we absolutely can tell the aggressive from the non-aggressive cancers with standard clinical information. And we can do even more by looking a little more focus on, again, the clinical information available for free on the clinical chart. PSA density, which relates the PSA to the size of the prostate, again, trying to rule out effects of BPH on PSA. We can look at subtypes of Gleason pattern 4. There's many subtleties that we're starting to use to improve risk stratification, again, for free. So do markers improve on this? Absolutely. There's 3 major tests. All of them have shown improved accuracy, improved prognostic power over the most sophisticated multivariable models based on clinical information alone. There's 3 of them. I'm going to go through these very briefly. Prolaris looks at cell cycle progression genes, 31 genes normalized to a set of housekeeper genes. This is done by RT-PCR based on prostate biopsy tissue, standard FFPE tissue. This one, combined with clinical and pathological information, is able to predict recurrence after surgery ranging from 0 to virtually 100%. We validated this in a number of cohorts over the years. More recently, based on biopsy tissue, they've shown that, again, the combination of the clinical and genomic information, if you're below a score of 0.8 on this scale, your risk of cancer mortality over the next 10 years is effectively 0. Again, very useful in helping men identify who should be going to surveillance for borderline cases. We don't do this for everybody. We do it for cases in which the decision about treatment versus surveillance is unclear. Oncotype, again, RT-PCR-based assay looking at 4 different pathways in prostate cancer biology. This one can shift men's likelihood of bad disease at time of pathology if we went to surgery up and down. About 50% of the men will have a shift of at least 5% up or down from the initial clinical assessment of likelihood of favorable pathology. And then finally, the Decipher Score. This one is looking at 22 genes in various pathways. The difference here is we're getting a full transcriptome assay on every clinical specimen sent. So this has allowed us to do a lot more digging into the biology. This is by far the best validated of the tests out there. There have been dozens of validation studies at this point looking at a number of different outcomes on both prostatectomy and biopsy tissue. And this one has allowed us to really get more sophisticated in looking at whole sets of different genetic scores concurrently because we are getting the whole transcriptome. So we can start to identify which patients with what looks like low risk disease actually have pretty aggressive biology across the whole continuum and across a number of different concepts of risk. It's also allowed us to dig deeper into the biology. And this is a fascinating piece of the study that showed that when we let these cases sort of cluster out in an unsupervised way, we see patterns emerge that look a lot like what's called the PAM50 classifier in breast cancer. And we're starting to see the same patterns emerging in bladder cancer and others. So we're finally entering this era that's been talked about for a long time, where we say less that this is a prostate cancer than this is a luminal B type cancer that happens to have started in the prostate. And that kind of understanding the biology will help us make better decisions about which treatments men should get going forward. Now, do these tests help us make better decisions today? This is much less clear. The science behind the development of the test is very solid. The science behind the way that information is presented to the patients is much less clear. And these tend to get developed by marketing departments rather than by scientists. And at the end of the day, we throw tons of numbers at patients with prostate cancer. Now we throw an Oncotype score at them or a Decipher score at them. Half the time, the clinicians don't even really know what to do with this, let alone the patients. And this is an area for very active research and need for trials. And we've got to remember that no prostate cancer test from PSA on forward in the continuum is truly binary. Everybody wants a pregnancy test that will tell us whether or not we should take out the prostate, but the reality, in fact, is of course much more complicated. So to sum up, prostate cancer really is entering the precision medicine era. The role for germline genetic testing is definitely expanding, although exactly what we do differently for men with these mutations is still very much in evolution. Pre-diagnostic genomic testing of the cancer tissue and related tests can help us decide, genomic testing of the urine and blood can help us decide who needs to go forward with biopsy, but PSA is not going anywhere as a wonderful initial screen when it's used properly, i.e. for younger men with a low threshold. Post-diagnostic genomics will help us make decisions about whom to treat versus surveil for selected borderline cases. And we're really just at the end, barely at the end of the beginning of the story. Very exciting space to watch. Thank you for your attention and hope very much to see you in person next time. It's a short trip after all.
Dr.
That was terrific. Thank you so much, Dr. Cooperberg. That was a fantastic talk. I think that there's so much heterogeneity within prostate cancer that it's really important to understand disease tempo in order to treat our patients well. As Dr. Cooperberg was saying, for our patients who have very indolent disease biology, we may not need to treat them. But for patients who have much more aggressive disease biology, perhaps treatment would be more warranted. So understanding and using these biomarkers to better understand about disease tempo, I think is going to be incredibly important as we get more towards personalized medicine. I wanted to shoot a question out to Dr. Son and Dr. Leppert to see at Stanford. We just heard Dr. Cooperberg's approach to the incorporation of genomics and genetic tests in screening and then potentially even post-diagnosis. Dr. Son and Dr. Leppert, are you using these tests at Stanford as well? Any thoughts on these tests?
I don't use them as much personally. I will use them in certain situations. So I don't do a lot of germline genetic testing. As Dr. Cooper mentioned, it's less clear what exactly to do with that information and how many people that actually helps with our decision making. I will sometimes use some of the tests that he mentioned pre-MRI, like he talked a little bit about the Exodx and the prostate health index and the 4K score. Sometimes I'll see patients that have come in and had 4 or 5 different tests. Usually they have conflicting information, and it becomes, in many cases, more confusing rather than more helpful to have a lot of those. So I will use those on occasion. I tend to skip more towards MRI because, in part, it has better quality evidence to date. I mean, this is one where there is level 1 evidence available to us, which does not exist with some of these biomarkers. I am hopeful that at some point in the future, it'll be more clear that there is a second level biomarker, perhaps after PSA, before we go to the MRI. The nice thing about the MRI is it tells us not only what is our overall suspicion for cancer, but also where that cancer may be located to help us with treatment decisions and targeting our biopsy. The biomarker tests don't tell us anything about the location of the tumor, so we would still need to go on and image afterwards. And then finally, where I will use some more of the genomic testing would be in men after biopsy in whom we're really on the fence about treatment or not. For example, someone with particularly high volume, low grade prostate cancer, or PSA is higher than we'd expect to see. I think those genomic tests can be helpful to push us either towards surveillance or towards treatment, or low volume, intermediate grade prostate cancer, where we could still consider surveillance. It's those guys who are right on the fence where I will use some of the genomic tests like the Decipher score.
Great, thank you, Dr. San. Dr. Lebert?
Yeah, I'll echo what Dr. San just mentioned, that it's those patients where the treatment is really unclear in terms of what's best for that patient. And in those select patients, we have been getting those scores at the VA. So my practice being based at the Palo Alto VA is a little bit different. The VA also has tried to lead the way on germline testing, and they've been trying to actually test every single patient who presents with advanced disease. And so I'm very sure that in a short period of time, we'll have a lot of information from these efforts at the VA to see where these tests can be useful for patients with really aggressive disease.
Great, thank you.
One plug I'll put in is that there's the Prostate Cancer Promise Registry that is enrolling patients nationwide. It's being led by University of Washington Johns Hopkins, but patients anywhere with prostate cancer can enroll in the registry, and they'll get free germline testing at home. And so that's, even for my metastatic patients, that's what I routinely will use if patients are able to fill out the online survey and do the online enrollment themselves. So I think I'll put the information in the chat for guests to see, to direct their patients to.
That's a great resource. Thank you, Dr. Kaki. There's a question about the place of genomics and selection of treatment options. In metastatic disease, certainly we have options for patients, for instance, with BRCA2 mutations that may be a candidate for a PARP inhibitor. However, in the localized prostate cancer setting, do genes like BRCA2 play a role in deciding one between surgery versus radiation or the addition of hormonal therapy? Is there any role for these genomic tests to help select between radiation or surgery?
I think to date, there's not a lot that tells us between surgery and radiation based on the genomic test. So I guess the quick answer to that is no. I think that there, again, can be helpful in deciding, if we move one step up, this question of, do we need to treat or not, which is always question number one when you talk to a patient with a newly diagnosed prostate cancer. And in that setting, I think it can be helpful. I think that the genomic test can be helpful also in men who decide on radiation therapy to decide, are they going to get androgen deprivation treatment or not? And if so, what is the duration of that treatment going to be? There is evidence that suggests that can prove decision-making with regard to that. But in deciding between surgery or radiation therapy, there's nothing that I'm aware of that's really been published that tells us, is this patient going to respond to radiation therapy or not? So it doesn't really help with that decision.
Right. I think there's another question about, does Stanford have a PSA testing algorithm, such as the one used at UCSF primary care?
I think we do not. I think that I do like the idea of an early test at a young age before we have this confounder of BPH. That's actually a little bit more in line with what's in the NCCN guidelines. I mean, one of the difficulties of this is you get different recommendations from different bodies about when to start screening. And so the NCCN is more in line with what UCSF is doing in getting an early PSA, say at 45. And then if that number is low, like less than 1, waiting 5 years before you do it again. And if it's high, following that patient much more carefully. So I don't think that we have that, but I think it would be a good direction to move into.
Right. There's a question about the use of machine learning and using these predictions and prognostic algorithms that they need to be continuously updated with new data. Dr. Kaki, I don't know if you would want to also comment on this, because I think this touches on some of your other work that you've done. But one thing that I think is also very important to consider is that these tests be validated on very heterogeneous populations to ensure that it's actually applicable for your patient population. Dr. Kaki, do you want to comment on that?
Yeah, I mean, I think that there's a lot of excitement about machine learning and AI. I think that the important things to consider, and I know Dr. Leppert has done a lot of work with this as well within the VA data set, is making sure that anytime you're using sort of, the machine learning AI technology, you have to make sure that you consider the data that's being put into developing those algorithms and making sure that they're validated across different populations. There's been some work that's even shown how some machine learning algorithms can be racist, that just sort of goes to show that the disparities that we have across medicine can also be picked up by machine learning algorithms. So I think that there has been more advancement with machine learning with imaging-based stuff. I think that with clinical prognostic biomarkers, I think that there's more work to be done before I'd sort of feel comfortable with adopting any of them universally. But a lot of exciting work that's been done there. I don't know, Dr. Leppert, do you want to mention anything further? I know you've done some work with the VA about this.
Yeah, I think one of the areas that the VA has had some success is actually not looking at prostate cancer specifically, but I think we can do a better job at estimating life expectancy when we have the information from the electronic health record. So when we're trying to select patients appropriate for screening or appropriate for a definitive treatment, I think some of these efforts will probably bear fruit earlier than some of the challenging aspects of trying to predict if somebody's going to have clinically significant disease or if they're going to respond to treatment A better than to treatment B.
Oh, go ahead. I was going to say, I know we're running sort of short on time. We have one more talk to get through. So maybe we'll sort of wrap up here. And if there's any residual questions in the Q&A, we can try to answer them through text. So our final speaker is Dr. Hella Borno, also from UCSF. She unfortunately also won't be able to be with us today, but she's an assistant clinical professor in genitourinary oncology at UCSF at the Helen Diller and Family Comprehensive Cancer Center. Dr. Borno is a close friend and was a co-resident of mine, and I have a lot of respect for her, and she's done tremendous work with disparities in prostate cancer and clinical trial enrollment. And I'm looking forward to her talk about prostate cancer disparities in the era of precision medicine.
Hi, everyone. My name is Hella Borno. I'm an assistant professor of medicine in the Division of Hematology Oncology at the University of California, San Francisco. I'd like to thank the organizers of today's event for the invitation to speak with you today. The topic of today's talk is disparities in prostate cancer in the era of precision medicine. These are my disclosures. Now, the outline for the presentation is shown. I'll first be defining health disparities, diving into prostate cancer disparities and looking at population level data, as well as prostate cancer disparities as it relates to clinical trial participation. I'll also describe disparities in precision medicine, the role of genomic testing in prostate cancer, and genomic testing disparities that we observe. So first, definitions. Health disparities are a type of health difference linked to economic, social, or environmental disadvantage. And health disparities research are designed to describe, understand, and address differences in health outcomes and aim to advance equity. Now, a commonly applied model in the context of health disparities research is the social or structural determinants of health model, which really just unpacks the different factors or determinants that are related to health outcomes and can be drivers of health inequities that we observe. We also frequently apply the socio-ecological model, which is grounded in a contextual understanding. It collects necessary data and uses appropriate analytic techniques, recognizing that health has an interaction with biology, and it's really about economic and social opportunities and resources, living and working conditions in homes and communities, behaviors, medical care, and all of these things interact with biology to determine our health outcomes. So this model is frequently applied in the health disparities literature. So let's think about prostate cancer first. And prostate cancer is a highly prevalent condition in the US. 9.9% of all new cancer cases in the United States are prostate cancer. And what we observe when we look at racial ethnic differences is that Black men are disproportionately affected with new cases of prostate cancer and are disproportionately dying from this disease. When we look at prostate cancer disparities in my own backyard in San Francisco and pull the population level data, what you can observe here in blue is that non-Hispanic Black men are disproportionately dying from prostate cancer related death compared to other racial ethnic categories. So these data really highlight that there are disparities in prostate cancer that are based on race ethnicity. So then we can look at the impact of stage at diagnosis on prostate cancer. And investigators, Ellis and colleagues, evaluated the extent in which stage has an impact on racial ethnic disparities. And what you're looking at here is the hazard ratio with different covariables that are inputted into a multivariable model to determine what are the factors that lead to the greatest change in the hazard ratio. And here, when you look at in blue, which is non-Hispanic Black, you see the largest effect on racial ethnic disparities is actually stage. So stage at diagnosis has the largest effect compared to these other covariables on prostate cancer survival. So let's think about the advanced stage context in prostate cancer and outcomes that we observe. Whitney and colleagues performed a very interesting study where they pulled VA data, which included 837 men with non-metastatic CRPC. And what they observed when they looked at the outcome of metastases-free survival, first positive bone scan, second bone scan, and bone metastases-free survival, was really no difference between non-Black versus Black patients with non-metastatic CRPC. So this analysis concluded that race did not predict the development of metastases among men with non-metastatic CRPC. They also looked at survival in this analysis and again did not observe a significant difference in survival among men with non-metastatic CRPC. So it suggests that these racial ethnic differences and outcomes are not as apparent once patients achieve the lethal condition of CRPC and prostate cancer. So if racial ethnic disparities disappear in more advanced disease states in prostate cancer, what could be other drivers that are contributing to prostate cancer disparities? So Ellis and colleagues did examine the role of healthcare payers in cancer-specific survival. And what they looked at was 5-year cancer-specific survival. And their study observed disparities in cancer-specific survival for men with public insurance compared to private insurance. And they actually found that the cancer-specific mortality increased from non-significant levels in 1997 to 2002 to 17% among those diagnosed from 2009 and 2014. So they observed significant changes in cancer-specific survival driven by payer in their data set. I've also performed analyses looking at the role of payer with prostate cancer treatment and management. And on a population level, my colleagues and I were able to obtain data of the de novo metastatic prostate cancer cases diagnosed within the California Cancer Registry. And we performed a multivariable model to identify what patients were receiving orchiectomy, bilateral orchiectomy versus medical androgen deprivation therapy in the management of de novo metastatic hormone-sensitive prostate cancer. And what we observed was there were significant differences based on payer, that patients with public or Medicaid insurance were more likely, had a higher odds of receipt of bilateral orchiectomy over medical androgen deprivation therapy in our cohort. So these data are some of the literature that suggests the role of payer in prostate cancer disparities. So I'd like to shift gears now and think about prostate cancer in clinical trials. Now, we'll first look at sort of low to intermediate risk prostate cancer. And of course, we all know the canonical PROTECT trial. The PROTECT trial provided level 1 evidence that there is no difference in prostate cancer specific mortality among patients who receive radical prostatectomy, radiotherapy, or active surveillance at 10-year follow-up for low risk Gleason 6 or intermediate risk Gleason 7 prostate cancer. But I'd like to highlight here that in this study, less than 1% of participants were classified as being of African or Caribbean ethnic origin. 98 to 99% of participants were ethnically white. Therefore, it lends itself to the question, is the PROTECT trial generalizable to more diverse populations with prostate cancer? Now let's shift gears and think about prostate cancer clinical trial participation in the advanced disease state. Spratt and colleagues actually pulled 7 landmark phase 3 RCTs that led to the FDA approval of 5 new therapeutic options in CRPC since 2009. And these studies were, defining for our standard of care, demonstrated improvements in overall survival, and met their primary endpoints. In totality, the pooled study sample was 7,275 men. However, despite this being a large pooled patient sample, only 3.3% of the entire study sample were Black men. Again, this lends itself to the question, are these studies in the advanced disease context generalizable? Now, I do just have to say, of course, in the context of multi-site international clinical trials that are recruiting from different countries with different demographics, the question of representation is not always the same. However, nevertheless, despite that, we really ought to be thinking about the ability to oversample minorities who will go on to receive study therapeutics in the real world after FDA approval. Now, let's think about the promise of cancer precision medicine and its role in prostate cancer disparities briefly. So we know that genomic profiling and genetic testing is increasingly the standard of care in prostate cancer, and inherited and acquired defects in DNA damage repair genes play a key role in prostate cancer pathogenesis. This is data shown by Pritchard and colleagues in the New England Journal of Medicine, which really highlighted this observation. And that among men with metastatic prostate cancer, approximately 12% have germline mutations, regardless of family history. And multiple highly penetrant genes and single nucleotide polymorphisms have been shown to increase a patient's risk of developing prostate cancer. Germline and somatic alterations in homologous recombination genes have been observed in about 20% of patients with metastatic CRPC. These data together highlight the role of genomic profiling. Now, germline genetic testing has 3 clear implications in prostate cancer. So the one that we most frequently are thinking about in the context of delivery of care is, can I find a genetic variant that allows me to use a therapeutic in a targeted fashion? So this is the treatment implication category of genetic testing results. But there are two other relevant categories, which is, can I find a genetic variant that actually increases a patient's risk of other tumor types, therefore providing me guidance on how to ensure this patient receives appropriate tumor surveillance for the other tumor types in which they may be at risk. And then the next category is cascade genetic testing. Can I find a genetic variant and then help my patient conduct cascade genetic testing, or the process of testing through a family in a specific order to identify all the relatives who did or did not inherit a genetic mutation that is causing a condition of concern in the family. So these three categories are extremely important in the context of prostate cancer clinical management when we discuss germline genetic profiling. Now, the NCCN, or our standard of care guidelines, are recommending germline genetic testing, especially among categories where there's a positive family history, high risk, very high risk, regional or metastatic prostate cancer, regardless of family history, Ashkenazi Jewish ancestry, or rare histology such as intraductal histology. Now, we also recognize, however, that individual pathogenic or likely pathogenic variants among men with prostate cancer differ based on race ethnicity. So my colleagues and I performed an analysis where we identified 1,351 men reporting a diagnosis of prostate cancer at any stage. And overall, in this study sample, 78% of men were of European ancestry, and only 3% were of African American or Canadian ancestry in this cohort. Now, 187 men, so 13.8% of this study cohort, carried a pathogenic or likely pathogenic variant, and the most prevalent variants were BRCA2, CHEK2, MUTHI, and ATM. And though age at diagnosis, ethnicity, type of family history with prostate cancer, and type of second cancer were not associated with the risk of pathogenic or likely pathogenic variant, the prevalence of BRCA1, 2, and APC varied by ethnicity, and 284 men carried a VUS, a variant of uncertain significance. So really what these data suggest is that there are differences in the rates of VUS detection among different racial ethnic categories. So the key conclusions that I want you to walk away from with this presentation is that racial ethnic disparities are seen in prostate cancer in the United States. Stage at diagnosis has the largest impact on prostate cancer survival. Differences in outcomes by race ethnicity may not be apparent in advanced prostate cancer, so in the CRPC context. Black patients are underrepresented in prostate cancer clinical trials, which leads us to question the generalizability of these results. And disparities in prostate cancer genomic testing exist and may widen treatment gaps in the era of precision medicine. So I appreciate your time. I'd like to acknowledge some of my colleagues who have been involved in the work that I shared with you today. And appreciate the invitation to speak with you today at today's event. Thank you. Hi, everyone. My name is Hella Borno. I'm an assistant professor.
Great. Thank you, Dr. Borno. We wish you were here with us today. I think we have maybe a couple minutes left for a couple final questions. I was going to see if Dr. Leppert is still with us. I was going to ask him at the VA, Dr. Leppert, you probably see a more diverse population, sort of a greater proportion of Black patients than we oftentimes see at Stanford. I was interested to know if screening is different for you for your Black patients compared to other ethnic groups or your white patients. You may or may not be there with us anymore today. Dr. San, any comments on that? Any thoughts from your perspective? Do you think PSA screening should start at a younger age for Black patients, or think about sort of, in light of the difference in incidence, and do you think you should screen differently?
I think recommendations have gone back and forth on this. And again, there's controversy about doing this. I think, again, like I mentioned previously, I think an early PSA is valuable both for Black men as well as other men as well. Again, whether Black men we ought to get that early PSA 5 years earlier. There's some debate there, and there may be some value. It's just always balancing this overdiagnosis problem and the added burden associated with the high PSA and leading to additional biopsies. So, I think getting an initial PSA, say at 45, is probably even more important for Black men than Caucasian or Hispanic or other men. But I think that's valuable really for everybody. So I don't treat them personally much differently. I just think it's important that we are screening guys of all ethnicities.
Maybe, Dr. Shaw, we can finish with a question to you. There's been a lot of talk today about germline screening. I think most of our speakers mentioned this in different occasions. How do you think about germline screening, especially for your medical oncology patients?
Thanks, Ali. What I'm seeing for the most part is actually screening for more advanced disease, for patients with advanced disease. So certainly all our patients in medical oncology that we see with metastatic disease, but now actually starting even earlier for those patients with high-risk localized disease as well. At the end of the day, germline mutations may not only play a role therapeutically for our patients, and we're still sorting that out. It certainly plays a role in the metastatic setting. Whether it plays a role in the localized setting is still yet to be determined. But I will say it does have tremendous implications in terms of family screening, which is very important for these patient populations. So I tend to send all my patients with advanced disease to genetic screening, as well as my patients with high-risk localized disease who may be seeing me for concurrent hormonal therapy while they're doing radiation, for instance.
Great, thank you. Sumit, maybe I'll turn it back over to you to just wrap up for the day. I want to thank personally first Dr. Son, Dr. Leppert, Dr. Cooperberg, and Dr. Borno, all for the excellent talks today. I think it's been a really exciting morning to talk about sort of the evolution of prostate cancer screening and diagnosis. And Sumit, any final words from you?
Thank you very much to all our speakers and learners for attending today's webinar. A truly informative session, which we hope will translate into clinical practice for many of you. Please see our upcoming prostate cancer series program, and we'll have more information posted here. And thank you again for joining. We hope it was educational.